Hello everyone and welcome to this session on interesting case study. I am Dr. Vijay Aithal. I am the professor and head in dermatology at St. John's Medical College, Bangalore, India, and I am pleased to share with you this interesting case which I am sure will not only be of interest to dermatologists but also those from other specialties. To begin with, these are my disclaimers requesting everyone to refrain from screen capturing, video or photographing either part or whole of this presentation. I have the following conflicts of interest, uh, but none pertaining to the present case report. I would like to thank Dr. Inchara, who is our Associate Professor in the Department of Pathology, Dr. Thomas Matthew and team from Neurology, and the Department of Surgery at St. John's Medical College Hospital. All right. So to begin with, uh, we had Mr. H.I., a 53 years old male who was a laborer from West Bengal in India. He presented to us with asymptomatic papules and plaques with dyspigmentation since the past 2 years, thickening and fissuring of skin of palms and soles since 1 year, asymptomatic oral lesions since 6 months, and before coming to us he had presented to neurology with diminishing memory and generalized weakness since the past 6 months. He also had visited the surgery outpatient department with pain abdomen of 1 month duration. As you can see, these are the small multiple asymptomatic papules, and few of them have coalesced to form plaques which were slowly increasing in size and number. There was also associated multiple teardrop shaped hypo and depigmented macules on a pigmented background over the back, and this has been going on since the past 2 years. There were also some of these bizarre looking hyperkeratotic plaques which were showing rapid increase in borders and atrophy in a few areas since the past 6 months. There were similar complaints in other family members, significantly his father and elder sister, but they did not have any neurological problems. They had only cutaneous lesions which uh, the patient had no photographic evidence of. He also had asymptomatic fissuring and thickening of the skin over both the soles and thick hyperkeratotic pitted papules and plaques over both the palms, and this was going on since the past 1 year. He has received multiple topical treatment for these lesions with steroids and keratolytic combinations multiple times, but without any improvement. There was the history of exposure to cement at his workplace, and he also had these asymptomatic grayish white papules and plaques, and few of them actually showed erosions, and this was going on for the past 6 months. One can observe tobacco staining over the teeth uh, since he was a chronic tobacco chewer. There was no high risk behavior either in him or in his spouse. Now, the other aspect, he had memory loss and weakness presenting as dementia, which was progressively worsening since the past 6 months. He was diagnosed to have Alzheimer's and was put on memantine, donepezil, and methylcobalamin, and with this he showed significant improvement. He was also a hypothyroid on thyroxine 25 micrograms. He had presented with severe pain abdomen with fever to surgery, where They suspected a right iliac fossa mass. Earlier, CECT at his local place had shown an appendicular mass. So with this background, I will pause here for about 15 seconds. You can think about the diagnosis and write down your likely diagnosis in this patient. We will come back after about 15-20 seconds and then discuss the case. Okay. So our differentials were lupus erythematosus with neurological involvement. Since he had many of these lesions on the sun exposed areas, but the dyspigmentation could not be explained. And to support our diagnosis, he also had neurological involvement in the form of dementia, which is not so common with lupus erythematosus. Graft versus host disease also was thought of, but the patient denied having received any form of tissue, organ transplant earlier. Uh, Heavy metal toxicity from groundwater contamination was also kept in mind, all the more because the patient belonged to West Bengal, and that is the arsenic belt of India. So with these in mind, we went ahead with the investigations. His blood picture was normal with a slight increased ESR. It was a hypochromic picture in peripheral smear. Blood biochemistry was normal. There was a mild increase in his retic count. The B12 levels was normal. Urine and feces routine examination was normal. Thyroid function was normal. VDRL and HIV were negative. Unfortunately, we couldn't do ANA and ANCA. One, because the patient could not afford any further investigations, and the neurology did not want to investigate further since most of the clinical picture by now favored a heavy metal toxicity. His ECG showed normal sinus rhythm, chest X-ray was normal, erect abdomen X-ray was inconclusive, CECT showed small collection around the appendix with perforation of the tip, probably a sequelae of acute appendicitis. Colonoscopy unfortunately could be visualized only till the terminal ileum, and this was normal with two small diverticuli in the cecum. MRI of the brain showed chronic small vessel ischemic changes with a diffuse cerebral atrophy. Coming to the histopathology, skin biopsy from the keratotic lichen planus-like lesions showed uh, acanthosis of the epidermis with loss of maturation in the epidermis and focal areas of sparring. The keratinocytes exhibited nuclear atypia but not in full thickness. So the pathologist uh, suggested that it could be a pre-malignant epidermal tumor, probably arsenical keratosis. And then we went on to do a biopsy from those thick hyperkeratotic bizarre looking lesions, and these were the findings. There was gross hyperkeratosis and parakeratosis. Uh, Also observed was loss of maturation of epidermis. There was a full thickness atypia of the epidermis with nuclear clouding and pleomorphism, and few of them also showed atypical mitosis. So with these features, the pathologist confirmed that it was Bowen's disease. Now going back and reconsidering your diagnosis with this picture in mind. Extensive lichen planus like lesions with bizarre looking Bowen's disease and uh, uh, on the trunk diffuse hyperpigmentation laden with multiple teardrop shaped hypo to depigmented macules. We could only think of chronic arsenic toxicity presenting as arsenic keratosis, Bowen's disease with Alzheimer's disease. Now, it was not certain if Alzheimer's was caused by arsenic exposure since patient unfortunately could not afford plasma or urine arsenic estimation. Treatment: we did an excision of the Bowens and cryotherapy with liquid nitrogen once in 2 weeks for some of the smaller lesions of Bowens. His treatment for Alzheimer's was continued with thyroxine and methylcobalamin. We thought of asking for urine spot test. It was suggested to the patient, but patient could not afford. Otherwise, 24 hours urine arsenic level and a plasma arsenic level with restriction of seafoods for 7 days would have been a good choice. We also gave a letter to the health authorities in the area to check groundwater level of arsenic in and around the vicinity of the patient's residence. We requested the patient to get his family members screened and also the neighbors for any signs and symptoms of chronic arsenic exposure. Unfortunately, patient was lost to follow-up since the past 2 years. Coming to discussion, arsenic is a heavy metal and is a major health hazard. It is a major contaminant in groundwater from industrial effluents. And as per Government of India, levels of more than 50 micrograms per liter of uh, palatable water is not permissible in the groundwater. Uh, it could also occur as a food contaminant, particularly in shellfish and other seafoods, and it often contaminates fruits and vegetables, particularly rice. There are many studies which have been done on lead poisoning. Unfortunately, arsenic poisoning has not received much attention. The clinical presentation is multi-system, with the cutaneous presentation being extremely rare. Hence, it can easily go undiagnosed, and hence one requires a high degree of suspicion, especially when patients present with these kind of lesions from the arsenic belt of India, which is the West Bengal, Jharkhand, Bihar, Assam, Chhattisgarh and Uttar Pradesh. And there have also been cases reported from Andhra Pradesh and Karnataka where the levels of arsenic in groundwater is quite high. Now, another word of caution: many of the proprietary non-allopathic medicines and so-called nutritional supplements could also have high levels of arsenic and other heavy metals which are not safe for human consumption. Now, why is it that only a few who are exposed to arsenic develop the symptoms and risk, and few of them don't? Many of them don't. So this could be explained by the polymorphism in the metabolism of arsenic, which is the methylation, and this polymorphism in the metabolism could explain some of them who are not able to metabolize arsenic can develop uh, risk of complications from arsenic exposure. The inorganic forms of arsenic are more toxic than the organic forms. The organic forms are the ones which are found in seafoods like shellfish. The trivalent forms are more toxic, while pentavalent forms are less toxic. The pathogenesis is by production of cellular ATP, which is severely affected, and hence other enzymes which are dependent on sulfhydryl binding are also affected. There is also an effect on production of glutathione, which is a potent agent to prevent oxidative damage, and this is also blocked. Also, nitric oxide production and availability is severely hampered. There is a higher risk of atherosclerosis and type 2 diabetes in these patients. Association between exposure to arsenic and development of Alzheimer's and gestational diabetes has also been proposed. There are no definitive evidence to link the two. And arsenic is presumed to be a carcinogenic substance with an increased prevalence of lung and skin cancer. So in acute toxicity, there is gastrointestinal symptoms of vomiting and severe diarrhea, which is rice water type. Dehydration and shock can also occur. Toxicity from arsenic gas exposure manifests as headache, abdominal pain, nausea, vomiting, acute hemolysis, hemoglobinuria, renal injury, and sometimes death. There could be cardiac arrhythmias with a prolonged QT interval, torsade de pointes, and ventricular fibrillation. Now, what we commonly see and what textbooks have described, the Mees lines, which are white bands across the fingernails and toenails, and alopecia may be seen after a few weeks. And chronic toxicity is more insidious in onset. The chronic onset exposure to arsenic can manifest classically as hyperkeratotic papules and plaques with a hypopigmented macules on a dusky background, what we classically describe as raindrops or dewdrops on a dusty road appearance. Pre-malignant skin tumors such as Bowen's, along with these hyperkeratotic lesions, should raise a suspicion towards arsenical toxicity. Painful paresthesia, which is symmetrical and Gloven-Stocking in distribution, or motor weakness and ascending paralysis can also occur. Liver and kidney damage, especially once hemoglobinuria has occurred, is quite common. The investigation should include a complete blood profile, biochemistry including thyroid function. A tick count is very important because we could check for hemolysis. Electrolytes, calcium and magnesium especially, should also be checked. Plasma arsenic level is not much useful in chronic toxicity. Rather, a urine spot test, or still better, a 24 hours urine arsenic level with an abstinence from seafoods for at least 3 days would be a gold standard. And also, estimation of the groundwater level for arsenic, and anything more than 50 micrograms per liter should raise an alarm to the health authorities. Arsenic can also be identified in the hair and nail clippings, and this is mainly used in autopsy, wherein more than 1 milligram per kg in dry hair or 1.5 milligram per kg in nail is used as a sure finding of poisoning. Imaging studies for cardiac and CNS PNS in peripheral nervous system involvement will be as indicated by the symptoms. There is a good clearance of arsenic by dialysis, hence hemodialysis may be indicated if acute toxicity is suspected. Chelation with dimercaprol and dimercaptosuccinic acid are very useful in acute toxicity to dislodge the bound arsenic. And there is also another drug called dimerval, which is used for acute toxicity. As far as the skin goes, cryotherapy, topical 5-fluorouracil, and excision in any suspected malignant or in situ malignancies is a must. So finally, to conclude, the learning points: arsenic is a heavy metal and a common contaminant in groundwater in the arsenic belt of India. These patients may not come to dermatologists in the beginning. They may seek consultation in neurology, cardiology or hematology for presentation which can range from Alzheimer's to hemolytic anemia. The classical cutaneous presentations are keratotic lesions with dyspigmentation, but any unusual looking lesion should always be biopsied to rule out in situ and overt malignancies. And it is important for a dermatologist to identify these lesions which are suggestive of chronic toxicity and have a high degree of suspicions for these unusual lesions. Arsenic is not only a medical problem but also an epidemiological problem which is at the community level, and hence involvement of local health authorities is very important. Prompt referral of water samples for levels of arsenic can definitely avoid future generations from being exposed to this heavy metal. So these are my references. Some of them have been extremely good articles which have been written, especially this one which is from Kolkata, from the All India Institute of Hygiene and Public Health, and the rest of them are articles which I could get on the internet. So thank you all for your patient listening, and hope we bring to you many more such interesting cases, and hope you enjoyed the session today. Thank you.